Hi, good morning, everyone. Hi, we're going to get started. It's my pleasure today to introduce today's grand round speaker, Dr. Omar Dhaybi. Dr. Dhaybi is a hypertension specialist with specialized training in resistant and secondary hypertension. He is a director of hypertension at the Mount Sinai Fuster Heart Hospital, and he trained in internal medicine at George Washington University in Washington, D.C., and completed a nephrology fellowship at the University of Chicago in the mineral bone diseases, kidney stone diseases track under the mentorship of Dr. Fred Coe. And then he subsequently completed a dedicated hypertension fellowship at the AHA Comprehensive Hypertension Center and holds a certified hypertension specialist designation from the AHA American Society of Cardiology. After working as a nephrologist in the private practice, Dr. Dhaybi actually recently joined the Mount Sinai Fuster Heart Hospital to focus on his area of expertise of hypertension. He has expertise in 24-hour ambulatory blood pressure monitoring and in renal denervation, and his practice focuses on treating adults with hard-to-treat resistant hypertension as well as patients with secondary causes of hypertension. Please welcome me in joining him up to the stage.
Thank you. Thank you so much for inviting me. It's a privilege to be here and to talk to you today about hypertension. So I'll be talking to you today about resistant hypertension. Is it a refractory disease or is it a refractory patient? I'm going to follow somewhat an unconventional, pathway because I really want to focus on the patient first, and then I'll show you the data about the disease. So those are my disclosures. So, looking at hypertension, we're not really doing a good job in controlling hypertension at the population level. So control rates 50, 60% at best, despite all the means that we have now to help us control blood pressure in our patients. So I'm going to talk to you about resistant hypertension. Resistant hypertension, the definition was formulated in the late 70s. And back then, they figured out it's difficult to control blood pressure on a good regimen. And back in the day, a good regimen included a diuretic, a sympathetic depressant like guanethidine, which we don't use anymore. It's a sympathetic blocker, or vasodilators. And then GNC5 in 1993, they adopted a clear definition of resistant hypertension. And the last AHA statement from back in 2018, they defined resistant hypertension as blood pressure of 130/80 or more on 3 drugs optimally dosed that work well together, and one of which is a diuretic which is appropriate to kidney function. Another element of resistant hypertension, someone who has controlled blood pressure on 4 drugs would also be qualified as resistant hypertension. Refractory hypertension, that's someone who's not controlled on 5 drugs, including a diuretic and spironolactone or eplerenone. So resistant hypertension is actually really common, 10 to 20% from observational studies. In clinical trials, it's much higher. So in ASCOT, all had 33% of patients, were resistant to treatment, 32% in ACCOMPLISH, 22% in SPRINT, more recent data, and ACCORD, 36% were resistant. So the prevalence is actually higher than what we think. So I'm going to talk to you now about one of the biggest challenges that we face in treating these patients. So this is the SYMPATHY trial, which is a renal denervation trial that was done in the Netherlands. This is a very homogeneous population that's presumably compliant. The study, I think, had 150 or 200 patients, something like that. And then look at this. So they analyzed the urine for drugs in every single patient, in both the arm that got the denervation or in those who were treated medically. So someone who was prescribed 3 drugs, most of them were taking 2. Some of them were taking 3. Some of them were actually taking 4. Some of them were taking none. And then when you look at 4 drugs, the vast majority were actually taking 2. Some were taking all 4, but some were taking none. And you see 5, the more drugs, the less the compliance. And looking at each individual class of drugs, 50% plus or minus, whether it's a diuretic, an ARB, or an ACE, beta blockers. Calcium channel, look at that, 33%. Um, so it's really striking. And then when in the protocol they adjusted the meds, to get these people under control. So and they looked at who followed the instructions. So a change of prescription, which was detected, and the same thing happens. 50% or less of compliance with adjustments in a clinical trial. And that's a big problem in the denervation trials specifically that has happened in multiple trials. So drugs don't work if you don't take them. That's, really the dogma here. And yeah, we looked at this a long time ago. So if you take a drug once a day, your compliance is high. If you take it twice a day, it will drop by 15%. And if you take it 3 times a day, we're in the 60% range, and so on. So it's really difficult for people to take a drug 3 times a day, plus or minus. And then this is another series. It's a primary care clinic that has a resistant hypertension clinic. And then, they analyzed 375 patients on 4 agents. And they analyzed the drug presence by liquid chromatography. And they had a non-adherence of 53%. 30% were not taking anything, and 70% were partially adherent. The vast majority of those were taking less than half of their drugs. So, you see that pattern that is coming back. And this is looking at each medication. That's why I call this a refractory patient or refractory disease. It's both. I think once we go through it, it will become, this is a real problem. And on average, if you look at all the observational studies that we have, 60%, 50, those are observational studies. So, partial adherence up to 66%, full non-adherence, meaning taking none, up to 35%. 50% at 1 year, stopped many of their medicines, when they looked at clinical studies. So how can we predict what can the patient do? You really want to look at the patient, as a whole, in his social, medical, and everything related to it. So, cognitive impairment is a big one. If your patient has memory problems, it will be much more difficult. Uh, a lot of people are concerned about side effects. And there's this cultural thing I'll talk to you about in a second. The provider-patient relationship is very important. Cost and the complexity of treatment. So the biggest problem is blood pressure doesn't cause symptoms. So, patients will take a drug, they don't feel anything, and then they take a drug and then they feel bad. So they're gonna say, hey, I was fine, you messed me up. Why did you do that? So that's the big problem. So there's no perceived efficacy that is tangible when they take these medicines, rather bar the number that they check, when they check their blood pressure. Side effects, obviously, a lot of people are concerned about side effects and being on medications for a long time. Complex schedules, multiple daily dosing schedules, education, very, very important to explain the natural history and why we are doing this, what our objective is. Um, stroke and kidney disease are the 2 things that really scare people. Heart disease, not really. You say, you're going to have a heart attack, say, okay, everyone will at some point. But, kidney disease is a big one. If you scare them with dialysis, they're going to change their behavior. And there's this cultural belief that's really widespread. They actually did a meta-analysis in 16 countries, and the vast majority of people relate hypertension to stress. There is a firm belief that, if you deal with stress, you become a happier person, your blood pressure will normalize, and you won't need any drug. And you'll see that in a lot of people who are not from here. This is not a problem here, but it's a worldwide problem. So whenever you're looking at your hypertensive patients, you want to see what drugs they're on, see what can be interfering. It's a pretty long list. One I would shed is herbals. Always ask about herbals. The ephedra, which is like an ephedrine analog, mawang, and antidepressant stimulants, obviously. Tyrosine kinase inhibitors, some cancer drugs really raise blood pressure by the way they work. So resistant hypertension is really a complex disease. So there's non-compliance, there's genetic factors, there's environmental factors, and the pathophysiology is mostly driven by sympathetic hyperactivity. That's a big one. And you see that when you look at the heart rate. When the heart rate is high, you can tell that your patient is sympathetically driven. And arterial stiffness, aldo excess, endothelin overactivity, and then you have more tubular sodium reabsorption and more volume expansion, leading to more target organ damage, which is a vicious cycle, which will make everything else worse. Sleep, insomnia and fragmented sleep is a big driver of resistant hypertension in general and resistant hypertension per se. It's not about how much you sleep. There's a misconception that, I get 8 hours of sleep, which is great, so that's good for me. Actually, it's not the amount of sleep that affects your blood pressure, but rather the type of sleep. So if your sleep is fragmented, meaning you're not getting a full 6 to 7 hours of sleep at night, that's going to fire your sympathetic system. That's going to activate all this cascade here. That's going to lead to fluid retention. Insomnia, not just sleep apnea, insomnia in general will lead to endothelial dysfunction and will raise your blood pressure. And I see this every day in the clinic. The patient will tell me, I had you look at the log, it looks terrible, and then 2 days it looks fine. I told him, well, what happened these 2 days? Well, he didn't eat out and he had a good night's sleep. It's a very fast effect when it comes to sleep. Aldo excess is a big component in resistant hypertension, and they looked at this in many studies. So here, looking at BNP and ANP, which are markers of volume expansion. So patients who have resistant hypertension have significantly higher levels compared to their peers who do not have resistant hypertension. And those with high aldo, when they measured their aldo on average, it was 13 nanograms per deciliter on the serum aldo. They had even higher fluid retention than those with resistant hypertension per se. So resistant hypertension is a state of volume expansion. I'll show you this in a bit. So renin, which it goes the other way, in this study, they looked at people with resistant hypertension and they treated them with amiloride and hydrochlorothiazide combo, and they looked at the renin response. The blood pressure actually went down by 30 points in those patients. This is a pretty old study. It showed that 18% had an escape phenomenon, and then 8 out of 60 turned out to have hyperaldo. Those were not screened, it was just discovered in the study. And you see those who got the amiloride and the thiazide had much higher levels of renin and aldo because the drug was working. So when you're evaluating your resistant hypertension patient, we talked about adherence and looking at the drugs and talking to the patient. And then you want to look at reasons for the patient to have secondary hypertension. Primary hyperaldo is by far the most common, 10 to 20% of patients. In resistant hypertension, it's actually up to 30% of people who can have primary hyperaldo. So it's very important to screen. Remember, if the patient is on spironolactone, you cannot do the screening. It has to be stopped for at least 4 weeks, ideally 6 weeks. Amiloride, you can get away with 3 to 4 weeks. And then CKD, obviously, is a big one. Renovascular disease, 25%. The renovascular disease is age related. So the incidence is way down in the younger group and way up, once you're above 65 or 70. Sleep apnea, up to 70% of patients with resistant hypertension. And the less common, rare ones, PHIOS and Cushing. So sleep apnea, we know the higher the apnea-hypopnea index, the higher the blood pressure. It's a linear association. And this is sleep apnea, not insomnia or sleep fragmentation. All right, so we talked about this. First, we define the patient. You want to make sure he has resistant hypertension. Next, you rule out white coat hypertension. So what we call pseudo-resistance. Patient is actually compliant with drugs and that they don't have white coat. This is usually done by either looking at their home blood pressure readings or by doing 24-hour ABPM. And then we look at secondary causes, and then you want to assess target organ damage. So LVH, coronary disease, proteinuria, CKD, and then vascular disease, ABIs, and things like that. So, and then one other component in resistant hypertension is what we call pseudo-resistance. The patient is not being actually properly treated. And a lot of times you get people on different drugs that are either not properly dosed or that do not work well together. So the one I see most commonly, someone who's on a beta blocker and on a losartan. This combination doesn't make sense unless the patient is sympathetically driven. So if the patient has a high heart rate or has an indication for a beta blocker. But a lot of times people just prescribe them for hypertension. They work on the same pathway. So when you want to tackle hypertension, you want to tackle multiple pathways at the same time. So, two drugs that work on renin and angiotensin, because beta blockers, the way they lower blood pressure, they're actually renin inhibitors. That's how they tackle hypertension. So they don't intersect well with ACEs or ARBs. In most studies, the simplest and most effective change you can make is actually to work on the diuretic. So we either increasing the dose or putting them on something appropriate for their kidney function. That's what really would make the biggest difference. And then pseudo-resistance, another part is physician inertia, which is a very important component. So this was first defined in 1998 in a major VA study, and the rate back then was 75%. We came a long way since then. So between 2005, 2012, only one of six, had an intensification of their regimen when they looked at observational data. And then 2018, people on spironolactone went up from 5.9 to 9%. So it's still kind of low, using spironolactone. And I'll tell you why spironolactone is the drug of choice in resistant hypertension. So I think we went through all this. And we touched this, it's attitude, belief problem, and time limitations. Obviously, it's hard these days to find time to talk to people, but, it's the essence of our profession. So, talking to the patient and establishing that relationship of trust where the patient will actually do what you tell them to do without being paternalistic. So I'll go through this at the end. So strategies to improve adherence. First, you want to identify it. Okay, that's step number one. And step number two, you want to really understand where the patient is coming from. In order to try to change behavior, we want to understand the behavior so we can intervene. It's very important. Actually, there are studies that show if you write down your instructions with your own hands, the compliance will improve. So rather than give them the discharge sheet, which is 90% of the time full of errors, medicines that are should not be there that are there, or things like that. If you write down, you take this drug, you stop this drug, the patient will take that paper and he will follow that instructions, because it's a liaison between you and the patient, a personal one. So, and then, use social network and help, from family members, people who have a say with the patient. And then use forgiving medications. And I'll talk to you about renal denervation when I talked about actual data about resistant hypertension. And this is really helpful way of lowering blood pressure. So in a European study, they found that 1 to 5 minutes were spent in half of the time talking about medications. So you see, it's not really enough, to go knowing how prevalent non-adherence is. Some thoughts about implementing a testing program, which is not a popular idea. Um, so very important to respect the patient's autonomy, their beliefs, and try to guide them and explain to them why we're doing this. So I'm going to talk to you about some data now for resistant hypertension. I'm going to start with lifestyle. So this TRIUMPH trial was published 3 years ago or 4 years ago, and they tested a very intensive lifestyle program. They called it C-Life, which included a nutritionist, weight loss program, exercise, extensive counseling, versus one session of counseling about the importance of lifestyle changes. It was 140 patients with resistant hypertension, and they found 12.5-point reduction in the extensive intervention arm versus 7-point reduction with the other one. So, stressing these factors will make a difference. Again, it's about time and resources. And what they found when they looked more closely at the data, that so the intensive intervention actually improved the baroreflex sensitivity, it improved heart rate variability, and it improved flow-mediated dilation, which is a measure of endothelial dysfunction. So what it really worked on was salt sensitivity and sympathetic overdrive. Everything else didn't light up. And then, like I showed you at the beginning, hemodynamic management is really the key here. This is an old study, but a very important study that was done at the Mayo Clinic. 104 patients, resistant hypertension. They randomized them into a hemodynamic arm going by weight, and they used bioimpedance measurement to measure fluid status, versus a hypertension specialist. And they found that the hemodynamic arm had almost 10-point less blood pressure than the hypertension specialist could do. And it was mostly increasing the dose of the diuretic, changing the diuretic class, using something that would work better. So in the CLICK trial, here they looked at CKD patients, CKD4, with resistant hypertension, and they were on a set regimen of an ACE or ARB, beta blocker, CCB, and torsemide. So they were on a loop diuretic. 60% of them were on a loop diuretic, and they randomized them to chlorthalidone add-on versus no add-on. So they added a thiazide on top of the loop diuretic. So what happened? After 12 weeks, there was 11-point decrease in the chlorthalidone group. The GFR as a whole was 20 versus 22, so it did not come down as much, but it was more of a response kind of thing. So I'll show you here. Creatinine increased 25%, happened in 45% of the chlorthalidone cohort versus 13%. So on average, patients did well, but some did not do well kidney function-wise. And it was obviously being on the loop diuretic that was the biggest risk factor, because those who were not on a loop diuretic, it was pretty even or close. So, but being on a loop diuretic, 59% versus 13% had this creatinine increase. So what they found that actually adding a small dose of chlorthalidone would really help blood pressure control without effect. So that'll be a compromise. And I think now the FDA just approved a low-dose chlorthalidone tablet, because we didn't have one. So it was only 25. Now they make a 12.5 milligram tablet. There's indapamide, who's available at 1.25. So that's the lowest dose for a thiazide, and obviously hydrochlorothiazide, which doesn't really work. So in ASCOT, they looked at, so ASCOT was a major trial they compared atenolol and amlodipine in people with high blood pressure, and they found that amlodipine actually was superior in cardiovascular mortality. Before then, so I think it was 2005, beta blockers were first-line treatment for hypertension with thiazides in GNC 3, 4, 5. And then after ASCOT and a few studies published around that time, it shifted the paradigm away from beta blockers to what we're doing now. So it was a huge study. I think they had like 20,000 patients. 1,400 actually got spironolactone as a fourth-line agent. And they found that those who got spironolactone, the blood pressure went down by 20 points or more after a year. So that, gave the idea of doing an actual trial, which is this is the most important trial we have in resistant hypertension pharmacology, Pathway 2, which compared spironolactone. So those are resistant hypertension patients on 3 drugs, and they compared spironolactone with doxazosin, bisoprolol, and placebo. So what they found, there was a 14-point reduction with spiro, 9 points with doxazosin, 8 points with bisoprolol, and 4 points with placebo. Spironolactone was superior to all drugs, and they used 25 and 50 milligram doses of spironolactone. 50 milligram would achieve 3 points, 3 millimeters, I think, extra reduction. So not a whole lot more. The harm may be higher. But then we have to remember this is a group that has normal kidney function. So spironolactone is a drug of choice in resistant hypertension in patients who have normal GFR. Their potassium was 4.1. Spironolactone significantly reduced the thoracic fluid index. So, some diuretic effect. The diuretic effect of spironolactone is dose dependent. So at the regular doses we use, it's not a diuretic. It starts being a diuretic at 50 milligrams, really at 100 milligram. But it did reduce the fluid index. The doxazosin actually increased it. So in all, 60% of patients who had spironolactone had to control blood pressure. 40% in the doxazosin and bisoprolol arms had controlled blood pressure. And then it was related to renin. I'll show you in a bit. In a sub-study of Pathway, they looked at amiloride too. So amiloride, they did an open label run-in, 146 patients, amiloride 10 milligram up to 20, and they compared it to spironolactone in that same patient population. Amiloride was actually better. So a 20-point reduction with amiloride versus 18-point reduction with spironolactone. Similar blood pressures at 6 weeks. And then the REHOT trial, here they looked at spironolactone and clonidine. We don't like to use clonidine that much. Surprisingly, clonidine did well in this study. This is a Brazilian study, only Brazilian patients. Control rate 44, 46%. So again, not great. In some endpoints, spironolactone was better. Overall, they were similar, blood pressure reduction-wise. Clonidine is not ideal, obviously, and clonidine has a paradoxical effect. If you use higher doses, it will actually start raising blood pressure when you're up to the 0.5 range. So I'm going to skip through this. And then the main problem with spironolactone is hyperkalemia. So the biggest predictors for hyperkalemia in any patient you want to use spironolactone on is GFR. So a GFR less than 45, it's not advisable to go for spironolactone unless you can manage, and potassium more than 4.5. So in the EMBER trial, they tried to get people on spironolactone forcefully. So they put them, so those were resistant hypertension, CKD 3, 4 patients, and they put them on patiromer, potassium binder, versus no potassium binder. And they looked, okay, how many we could keep on spironolactone versus how many had to stop. So 69% were on 50 milligram versus 51% in the placebo, so significantly more. Only 7% in the patiromer arm stopped the spiro versus 23% in the placebo. And the blood pressure was obviously better by like 4 points in people who were on spironolactone. And then you see this is the hyperkalemia onset, and you gain a lot of time with spironolactone. for like potassium elevation and the time you had to stop spironolactone when you use a potassium binder. Still, up to 20% of patients had a significant decline in their GFR. Because remember, those are 3 and 4 patients, so they're more prone. Amiloride, pathway showed it's similar to spironolactone. Meta-analysis data, spironolactone is slightly better than amiloride in blood pressure reduction, which is better than eplerenone. So eplerenone would be the weakest of the 3, and then spironolactone. And so they just, published a study in JAMA a month ago, looking at amiloride in resistant hypertension. This is a Korean population only. That was done in South Korea. So a change of 13 points with amiloride, 10 milligram. They used 10 milligram dose versus 14.7. So very similar reduction with Spiro, 25 milligrams. And looking at morning and evening, everything was pretty much the same. I'll skip this. So, okay. So amiloride is an option. Amiloride, I don't think I didn't put this, but amiloride, the advantage that amiloride provides in comparison of Spiro, it's not related to renin activity. So Spiro works the best when the renin levels are low. So when renin is suppressed, Spiro, becomes really potent. Amiloride doesn't have that. It's independent of renin. So it's more versatile if we want to use it. And then I'm going to talk to you about renal denervation. So back in the day, 1940s, they used to treat hypertension surgically because they had no drugs. So the first hypertension drug, I think the diuretics came down on the market in the 50s. The first drugs that they used to use back then, I think, was reserpine, which we don't use anymore. So they actually did a surgical splenectomy and a open sympathectomy to treat hypertension. The largest series, 1,200 patients, had this procedure, and blood pressure improved in only 50%. And 100% had, they couldn't control their bowels or their bladder anymore. They had severe incontinence, severe orthostatic hypotension, and ED. So it was a terrible treatment. But this idea of lowering blood pressure by targeting the sympathetic system, that it comes back as far as this, because we know that this afferent kidney, innervation regulates blood pressure through norepinephrine, through vasoconstriction, and through renin and aldo and volume retention. We know that when we stimulate the renal, sympathetic nerve, the renin concentrations goes way up, sodium retention goes way up from animal studies, and renal blood flow goes way down. So this idea of treating locally the sympathetic system, came 20 years ago or more, because if you look at the anatomy, we know that those sympathetic fibers, they concentrate around the renal artery. And when you're more proximal, they have an even distribution. As you get more distal in the artery, they become more central. So the more distally you go, the more central they become. So we have 3 devices to do this, the renal denervation, the Medtronic one, which is a 4-electrode catheter that generates radiofrequency energy at each tip. So they, circumferentially, they go through the vessel wall, and that energy will emit radiofrequency energy that goes through the wall to the nerve fibers that are around the artery. The Paradise system is an ultrasound system. So it's a balloon, they put in the proximal part of the artery, they inflate, it will generate ultrasound energy that will treat those proximal renal fibers, sympathetic fibers. The Pergrin system is an alcohol-based that's not FDA approved. The other 2 are FDA approved. So when they tried this in 2010 in Simplicity 2, which was the phase 2 study, they had spectacular blood pressure reduction of 30 points in patients who had denervation. So Simplicity 3 came. Dr. Butt, he's our director of cardiology. He was the lead PI on this study back in 2014. This is the largest renal denervation trial to date. And they picked very resistant patients and with a GFR of 45 or more, and they randomized them to renal denervation versus a sham procedure. And they used the first generation flex catheter. This first generation catheter had only one electrode. So the new catheter has four. It's a lot more efficient in ablating the renal nerve fibers. And 29% up to 29% in this cohort were on spironolactone. So what did they find? So with the sham procedure, there was an 11.7-point reduction in blood pressure, which was spectacular. We don't usually see that. Most studies, you're going to see 2 to 5, 6-point reduction with placebo. With the denervation, there was a 14-point reduction. So the trial was negative. It did not reach statistical significance. And the ambulatory blood pressure reduction, same, 6 versus 4.7-point reduction. And then, when they tried to look at those results more closely, younger patients actually responded. Patients who were not African Americans responded really well to the procedure. And who else? And those who had a normal kidney function. So those who had a normal kidney function also responded well to the procedure. So 33% of patients did not have a response. So 67% responded to the procedure. A lot of things have been said about simplicity. I mean, the large placebo effect was unexpected. And adherence was a big thing. It was a big thing, but the biggest thing was the catheter itself. It was the first generation catheter that only had one electrode, and 30% of people who did the procedure only did one. So they didn't really have much experience with it back then. And they did not ablate accessory renal arteries, which are very important. 1 out of 5 patients will have an accessory renal artery that needs to be ablated as well. And then when they looked at the number of ablations, the more ablations that were done, so the more treatment that was done, the lower the blood pressure, up to 20-point reduction in more than 13, 14 ablations. The less ablations, obviously, the less reduction. And then they followed patients. So these patients were unblinded after 6 months. So after 6 months, patients were told if they had the procedure or not. And they were given the choice of having the procedure if they wanted to. So 101 patients crossed over from the sham arm to the denervation arm. Only 70 patients stayed in the non-denervation arm. In those patients, there was 6-point reduction in blood pressure at 1 year versus an 18.9 reduction at 1 year in the original denervation arm and a 17.7 in the crossover arm. So those who had the denervation after 6 months fared similarly to those who had it from the beginning. And those who did not stayed where they are. So 36 months follow-up of that same cohort. So we're at 26-point reduction. This is an open label follow-up, so now physicians can do whatever they want. They can add as many medicines as they want to these patients. So there's a 20-point difference between the two arms in those who had it or those who did not have it. And you see that, nice separation, which we see in all renal denervation studies, separating the pre and post, and it's consistent throughout the day and at night, most importantly. So the Simplicity was the US trial. The Radiance was the European, cousin of Simplicity. So resistant hypertension, in Europe, they use a GFR 40 as a cutoff. And, they had them on a set regimen to improve compliance. And then at 2 months, so there was an 8-point reduction with denervation versus 3 in daytime. This is daytime ambulatory blood pressure. This is not office or home. So a 5-point difference would translate maybe to a 10-point difference for home or office, for office mostly. And then office, you see there was more reduction at 2 months. Nighttime, significant reduction. 3% needed spiro versus 10%. and they ablated the accessory arteries. In most denervation studies, you'll see they look at, I didn't put it here, but they look at escape phenomenon. So they tried patients on no drugs for 2 months, and then they see how many need to go on the escape route because their pressure is too high. And across the board, it's triple, 2 to 3 times more people in the sham arm that need to go on the escape protocol because they need intervention. And you see that same separation in those curves between the denervation and the sham. The European Society of Hypertension guidelines, it is a class 2B for resistant hypertension, a class 2B for hypertension in general. They recommend, this is done in specialized centers with high volume and expertise in the procedure. The European Society of Cardiology, it's a class 2B level A for resistant hypertension, 2B level B for hypertension in general. The American guidelines, they're supposed to come out this July. So we'll see what they say. They're going to address renal denervation because the 2017 one did not, because there was no data back then. So, so the benefits really is the adherence thing. So you take away that, that concern that the patient is not taking the drug. This is like a depot drug that the patient has and will stay on. There are questions about regeneration. We don't know. I actually saw a patient a couple of weeks ago. She was 71. She was in the original Simplicity study. And she had a really great response. She stayed on a stable regimen for 10 years. And she came back from Massachusetts. She drove for like 3 hours because she was asking, can I have it again? Because she noticed after 10 years, it started weaning off. So now she's on 5 drugs and nothing is working. But now she's 84. So I told her, we can do it. I'm not sure we're going to have the same response as we did the first time. So adherence, big one. So if you compare drugs and denervation, on average, the totality of the studies we have, it's equivalent to a drug. On average, it will lower blood pressure anywhere between 5 and 10 points. So it's like adding a drug. It's a responder, non-responder as well, more than just lowering blood pressure. Some people will respond and some people will not respond. And I'll show you how we can tell. So, it's a pretty straightforward procedure. We just did one yesterday. It takes like 45 minutes. It's like a heart cath. It's a, same day procedure. It's really safe. The cost obviously favors medicines and generics, which cost nothing. But think about this: is if a drug costs $1, how much will it do to you? I feel like in life we get what we pay for, unfortunately, and then what the patient prefers. So this study, they looked at they compared the drugs and denervation over time. So look at this: 1 drug, 2 drugs, and 3 drugs, and this is the blood pressure reduction over 24 hours. So, those drugs will work in the daytime, but as you get through the night and the early morning, which is the most critical time, for having cardiovascular events, you see the effect weaning off versus denervation that has consistent effect. And the separation is actually the highest during that period of time. And this is from a negative study. So this data comes from a negative study. I think it was the Achieve trial, if I remember. So, and then blood pressure lowering effect is independent of salt intake too, because most of the drugs we use will be related to how much salt the patient is eating, because if the patient is eating too much salt, their renin is low, so ARBs and ACEs and beta blockers will not work. So the best candidates for denervation are those who are sympathetically driven. Those are the patients who respond the best. So how do you know if someone is sympathetically driven or not? They have a high baseline heart rate. In the studies, the cutoff was 73. So anyone with a heart rate, 75 or more will likely benefit from the procedure for uncontrolled hypertension. It doesn't have to be resistant. And then if they have orthostatic hypertension, meaning when they stand up, their blood pressure goes up. So that's a very important marker. So someone who keeps going to the ER with hypertensive emergencies or urgencies would be a great candidate because this way you improve compliance. It's not going to work straight away, like I showed you. It takes time, but over time, the buildup will help you control blood pressure over the long term. So people who have problems with medicines, who are non-adherent, who are intolerant to medicines, and so patients with resistant hypertension, you want to choose them carefully. I think the highest priority should be given to those who have target organ damage because those have the highest cardiovascular risk. So lowering blood pressure, by 5 points, by 2 points will lower risk by 10%. So, 5 points, 20%. So any lowering we can do will help the patient over the long run, specifically LVH, albuminuria. Someone who had a TIA, I think, would be a great candidate too. And the procedure is very safe, I'll show you. So 0.2% annual incidence of renal artery, complications from the procedure. Uh, I think the most common side effect was pain. So 12%, and that would subside after a few days after the procedure. In general, we tell people, vascular complications less than 2%. So it's pretty much like a kidney biopsy. Um, who are the patients who should not have it? If they have renal artery stenosis of any kind, they should not have it. If they have an aneurysm, so if the vessel size is not adequate for denervation, so they measure this when they do the angiogram. If they have a stent, if they have FMD, if they have a single kidney, that's a contraindication. So a transplant, pregnancy, obviously, we don't have data. So before you refer someone, you want to make sure they don't have white coat hypertension or secondary hypertension. So very important to wear this up first. I think what we're lacking is means to assess how much the denervation is done properly. And there are some studies going on in assessing real-time denervation on the table, like how much denervation we're achieving. Because we know it works, maybe we're not still doing it properly. So I'm gonna skip this. And then I'll talk to you real quick about, the new drugs that were approved for resistant hypertension, aprocitentan. It's a dual endothelin AB antagonist. So it's a descendant of atrasentan, which was tested in SONAR in diabetic kidney disease. Good drug, slows down kidney disease progression, lowers proteinuria, but it causes heart failure. So it was a failure. So this drug is an upgrade because this one is a dual endothelin A and B blocker. So when you block both, you lessen the edema significantly, which comes from unopposed stimulation of the B receptor. So if you look at the data, blood pressure reduction. So this is resistant hypertension where they compared patients, on multiple doses of aprocitentan versus placebo. And this is a CKD population. So, a lot of them had CKD. So the blood pressure reduction, it wasn't great. It was significant, but not as much as they hoped for, 6 points. It really lowered proteinuria by 30%, which is very important in CKD. The edema, roughly half of what they got in SONAR. So in SONAR, they got like 40% edema with atrasentan. Here, it was 18% at the maximum dose. So only 7 patients had to stop it because of the edema. Heart failure was still threefold higher than placebo, but significantly lower than the previous endothelin. So this drug is a good drug. It's not for everyone. It's an option in the right patient. Again, it's all about patient selection in reducing blood pressure. So, and then the aldose synthase inhibitors. So the baxdrostat, which was the second one, it inhibits the enzyme aldose synthase, which is 93% similar to the cortisol enzyme. So that's the problem, and it took so much time to create a drug that would work without causing adrenal insufficiency. So in the brig hypertension, where they use baxdrostat at multiple doses, looking at resistant hypertension, spectacular 20-point reduction. So that was, very promising. But then, unfortunately, in the HALO trial, which was the phase 3, it was not significant. So now they're redoing the phase 3 trial, because in the phase 3 trial with baxdrostat, there was 17-point reduction with placebo. So that was just like what happened with Simplicity, which was too much. And look at this. So going back to the beginning, it's always about going back to the beginning. 36% of patients who were supposed to get 2 milligrams of baxdrostat had a level of 0 when they were tested. So, and then lorindrostat, this is the last one. I'll skip this one. The latest trial was published a month ago in the New England Journal. This is not resistant hypertension. This is uncontrolled hypertension. And it lowered blood pressure by 15. So if you look at baxdrostat, that 7-point reduction with placebo, the trial was significant. The placebo in the baxdrostat was 16, 17-point reduction. I mean, it's impossible to have a positive trial when you have such an effect. Again, going back to compliance, it's much more complicated than we think. So it was really safe. One thing lorindrostat causes, it works like Bactrim. It will, interfere with creatinine secretion. So it will raise creatinine without actually causing kidney problem. So that's why they use cystatin in this trial. Hyperkalemia incidence was actually low, and no patients had adrenal insufficiency. So I'll skip this. So as a summary, volume is a key in managing resistant hypertension. Choosing the right diuretic, someone who has, you can use chlorthalidone, switch to a loop, when the GFR, you can get away with chlorthalidone up to a GFR of 25 if the patient is responding. You look at the heart rate, and then you can intervene there. And then, try to work on adherence and the dosing, multiple pills, single pill combinations, 2 or 3, to improve compliance, work on sleep, and renal denervation. I think it's a really important add-on that should be streamlined. And I'll finish with this very interesting, actually, this is approved in Europe. So back in the day, the trials with baroreflex stimulation therapy, spectacular blood pressure lowering, 30 points, like within a week. But the thing is, they had strokes, high rates of complications. So they perfected a new device, which is not a baroreflex stimulator, it's an amplifier. So they implanted, so this is approved in Europe back in 2017. It's still not FDA approved. The CALM-2 trial is ongoing in the US for this one. So they actually put it, endovascularly in the carotid and leave it there. It will inflate and stimulate the baroreceptor. The safety profile is so much better. So only 2 patients in the European cohort had a TIA that they think is related to the center, not to the device itself. The responses are like 30-point reduction, 25-point reduction, which is very quick and sustained over 3 years. So this is really promising. Hopefully this time it works, because the baroreceptor stimulator was a disappointment, unfortunately. And I think that would be it, right on time.
Well, thank you so much for the tour de force in hypertension. Before, as individuals are thinking of questions, taking us back to, on a more practical basis, taking us to the clinic, how much, when we are seeing patients in clinic, how much does patient positioning affect the blood pressure measurements? Because often patients kind of rushed into the room, blood pressure is taken, and then it's high. So what are the best practices for the clinic?
So the best practices, the AHA recommends, 5 minutes of rest. Patient is on their own. You check the blood pressure 3 times in a row, 1 minute apart, which is very difficult to do in the office setting, obviously, because of the time constraints. In my practice, I take office numbers in consideration. but it's always, good to look at home blood pressures. Home blood pressures are roughly, I mean, the gold standard is the 24-hour ABPM. So if you have any doubts, you can do one, and we do them, in the clinic, on a daily basis. But home blood pressures are as good. Usually, I recommend, patients check their blood pressure in the morning at home, when they wake up, before they take their pills, after they empty their bladder. So I tell them, sit down, relax, back supported, arms supported, feet touching the ground. It's very important to measure blood pressure correctly, because you're relying on a number. If you're not getting that number correctly, then your whole assessment will not work. So so they have to be back supported, arms supported, feet touching the ground. I tell them, check it, wait for a minute, check it again, wait for a minute, check it a third time. And they average the second and third number. I have a lot of people who are very anxious, tell me, you know what, I never check my blood pressure, because whenever I check it, I'm more anxious, it will be higher. So in these people, and there's a lot of people like that. So in these people, I am even more forceful. I tell them they'll check it 6 times, 1 minute apart, and you'll see it's gonna come down, and just take the last one or last two. Still 50% will not do it, because I mean, this stress thing is real, and a lot of people have an issue. And the asymptomatic nature of hypertension is the biggest problem. You're not treating a condition that you can tangibly assess what you're doing, rather just by a number.
Are there questions? Yes.
So how effective do you think constant like in treating this and dealing with the clients? So we use, I mean, unfortunately, that's why I really stress renal denervation. I think renal denervation, you should be in the algorithm. So usually when we treat blood pressure, you think of, what am I going to use? We use ACEs, we use ARBs, we use calcium channel blockers, we use diuretics. Once you're through that and the blood pressure is still high, then what next? Well, the data tells us spiral. If the GFR is normal and the potassium is okay. So we don't think about that. And then what next? So everything that comes next is a problem and a solution, because all these drugs that we use are terrible. So you saw doxazosin works. It lowered blood pressure by 9 points, but then it will increase the fluid retention status. So it will counteract what you're trying to do. Minoxidil works. It lowers blood pressure, but then, it causes pericardial effusions in people who have heart disease and severe fluid retention. So all these other drugs, clonidine, I use the patch. I don't use the pills. So when I have to use it, I use it. I mean, most people will complain of somnolence. They will feel more tired. It does lower blood pressure, but this is the best we have. So, I think I would consider renal denervation at an earlier stage to make it easier, because once we're in the minoxidil doxazosin stage, here we're not, in a good spot. There's a lot of studies that are happening. I think this is going to change, because now, they're testing the angiotensinogen blockers, mRNA inhibitors, so the injectables that are given once every 3 or 4 months. And those seem to be working really well. They're tested in uncontrolled hypertension. So the next step would be to use them in resistant hypertension. I think those will change, the layout of the field. And there's also another injection for ANP analog, MANP, which is, an natriuretic kind of thing that seems to be very effective too. The trial is ongoing. I think they had to stop it because 3 patients had severe hypotension or something like that. So, but it's ongoing. So they're revising the protocol and things like that. But, I think the options will change in the next 5 years. We'll have a lot more options than clonidine and minoxidil.
Last question.
This talk is loaded with pearls. Then modify my practice. Thank you. So, many questions. Most troublesome thing I have in my practice, and I use ambulatory BP and all, is you have these patients with stent vessels, and their pulse pressures increase, the diastolics drop, the systolics go up. And then when you chart it, it's a mess. And then you go, let's say, to a blood pressure of 140, next thing you know, the diastolic is 50. They all have non-specific complaints. You never know if the complaint's related to the diastolic or 50 or not.
whole thing is actually extremely complicated. And that's subset of patients that would like to know.
Well, if it's 50, it is related. So, most of the data that we have when the diastolic goes below 55, you're going to have problems. Actually, cardiac ischemia starts, happening at 50. So diastolic is a big, big, big deal. So especially those are isolated systolic hypertension patients. So actually, these people did not respond well to denervation either. So those are the most complex, and it's mostly salt sensitivity. So if you go through the diet, you're going to see those people are the ones that need to be the most draconian with salt restriction. So I usually tell them to consume between 1,000 and 1,500 a day, because that's really the foundation for any blood pressure control going forward. And then using drugs that work well with salt sensitivity, so calcium channel blockers, so vasodilating nitrate generating drugs, vasodilators, calcium channel blockers, nebivolol, which is the only beta blocker, not the only one, but the best beta blocker with nitric oxide generating activity. Nitrates, I actually use nitrates in these people, just plain nitrates, and they do work much better than in a regular hypertension patient. But I would say the foundation is salt. If they can stay below 1,500, it will make the biggest impact, and you don't want their diastolic to drop below 55. So they're going to live with a systolic in the 140s or 150s. That's fine. The risk is there. We're not gonna, take away risk, but the risk exponentially goes high when you're at 160 or more. So, most of these people will live happily in the 149, 150 range over 60. That's fine. They're gonna have a normal lifespan and hopefully no complications.
So much.
All right.